This is Jarrett McGinnis, and this is my single case design assignment from my work with James Mayfield, which is an alias I'm going to use for a client that I worked with in my field placement at Cooper Reese Healing Community. And this is an assignment for personal practice evaluation. Some demographics on James. He's a single white male in his early 30s from New Jersey. His mother and father have been divorced for approximately 10 years. His father remarried about 5 years ago. His mother did not remarry. And the client has a very enmeshed relationship with his mother. He has one sibling, a sister who's 3 years older than him. That is also a very tumultuous relationship. Client is in very good physical health, has a history of being an excellent athlete. He completed an undergraduate degree. He has a history of problems maintaining or attaining work. He was most recently an Uber driver, which was kind of his last go-to, as he could work that job with virtually no accountability or need to maintain uh, a routine, consistency, or workplace relationships. He has had previous diagnoses of generalized anxiety disorder, obsessive compulsive disorder, and major depressive disorder. He's had 3 previous hospitalizations for suicidal ideation, and a history of treatment with CBT, DBT, transcranial magnetic stimulation, electroconvulsive therapy, and selective serotonin reuptake inhibitors, and antipsychotics, and mood stabilizers. One thing that I would point out is that the client is pretty frustrated at this point in what has been about a 10-year ordeal of treatment and trying to pin down what's going on with him, experiencing quite a bit of treatment fatigue. The presenting problems that he came to us with are intrusive thoughts, suicidal ideation, poor emotional regulation, depression, anxiety, and impulsive behavior. He's currently living in our residential mental health center. His mood is labile, his affect is flat and mood congruent, his cognitive abilities are intact, his thoughts are very obsessive and repetitive. He has a high IQ, as evidenced by using a large vocabulary and kind of pulling his weight really well in any conversations with our clinical team. His station and gait are within normal limits. He has intermittent intrusive thoughts of suicide, no history of attempts, and one thing that I would add about the nature of his suicidality is that it was of course taken seriously, but often deemed to not be an imminent risk. It was oddly intellectualized. A few examples would be it's 8:30, the Joneses are getting up to go to work. I don't have a job. I haven't been able to keep a job. One in this situation should consider taking his own life. That's kind of a play-by-play of what his thought process does. That it's almost as if he's been deducing the idea that suicide makes sense for him without kind of an authentic desire to take action. And there's never been the development of any specific plans to take his own life in his entire history of illness. The onset of his psychological symptoms was in his early 20s after college. He has a history of learning challenges, and there was a rule-out diagnosis from several previous providers for an autism spectrum disorder, but he was always in typically developing classes and never had an individualized education plan in school. He has strained relationships with his parents, his sister, his extended family, and virtually any friendships that he's maintained as well. I think one thing that's been really prominent in his presentation is that during moments of distress, his own needs to regulate his experience or get to feeling better take precedent over any social mores, the needs of others, and he can often be pretty combative, lash out against supports who he feels have failed him, which certainly includes his parents and many previous providers. And a lot of that last material that I discussed has kind of led us to conceptualize that there's a strong uh, narcissistic personality adaptation component of his diagnosis, but there's no formal diagnosis from us or in his history related to personality. In working with James to quantify the problem, we agreed on defining kind of this bundle of problems that could just as easily be defined as distress, anxiety, poor emotional regulation as impatience, mostly due to the fact that these symptoms kind of compile in a way that have severe consequences on his decision making. When he's in an emotionally dysregulated place, he will make behavioral choices that are completely irrational and against longer term goals, even shorter term goals. An example would be he's progressing in our program, working toward transition to our community program, and then in a relatively short moment of increased distress, he elopes to our farm campus, and the breach of trust causes a setback. He needs to rebuild trust and re-engage before we can continue our momentum in working with him. The problem could also be defined as poor impulse control, uh, but impatience is the language that James agreed to in our conversations about it. We created an individualized rating scale due to the really kind of individualized way in which we conceptualize the problem. The scale is below, as well as the log. You'll notice uh, that we created custom tailored anchors with examples from things that kind of meet different criteria for what James might be experiencing when he's feeling content versus some impatience or quite impatient or at a most impatient or distress crisis level. And then to the right at the bottom is the log that James is going to use to record a rating for his daily level of patience, along with any comments about the kind of happenings of the day. After reviewing baseline data, James set the goal to increase his patience. As you'll notice below, there's not really a stable baseline. It looks as though there may be some trend toward deterioration toward the tail end of the baseline week, but not any marked trend or any reason to suggest that an intervention would not be a good idea. So for the case conceptualization, James's intrusive thinking and obsessive thoughts revolve around pessimism about the future and regret for the past. This rumination causes significant emotional dysregulation in moments of distress. James will take almost any impulsive action in hopes of changing his experience. He becomes very demanding, and his own emotional needs take precedent over the needs of others. This has damaged nearly all of his relationships. James's reliance on interpersonal validation and personal achievement, those are kind of referencing the narcissistic qualities that I mentioned. These are pitted against his challenges to make thoughtful, rational decisions while in distress. The consequences of his choices then increase his distress, and this cycle kind of continues. So just to kind of lay out, the problem's been identified as impatience. That's the language we chose and that James chose. The goal is to increase patience, and the objective is to achieve patience scales of 3 or lower daily. For the evaluation design, I chose a simple A/B evaluation design. After baseline measure and the introduction of the intervention, James preferred continuing the intervention to discontinuing it in an effort to determine its relationship to changes in patience. And that was due to just not wanting to risk deterioration of his patience levels. And that actually, it's arguable that his patience levels had not improved. Very arguable. So it may have made more sense to try an AB just to see if the intervention, withdrawing the intervention, had some impact. Um, it seemed prudent after a week of the intervention to ask James to track his engagement with the intervention. So weeks 2 through 7, James engaged in intervention tracking, which, if that were to be considered a second intervention, would make the evaluation design an ABC design. Some things we used to try and increase the validity and reliability of the measures. We reviewed the measurement instrument and the anchors on a weekly basis to make sure that the anchors and the measurements he was, or the ratings rather, that he was selecting still resonated and felt like accurate depictions of his day-to-day experience. I also had collateral information through communication with his family and with other members of the clinical team regarding his mood and level of distress, to kind of compare with the numbers that he was giving me about his perception of his own experience. And we saw some interesting things there, and I can talk more about that later. The intervention is based in a mindfulness-based cognitive intervention practice model. So we decided that James would have a self-guided practice of using the Insight Timer app, which has just a huge catalog of short, to the point mindfulness meditations, guided meditations that one can select and listen to. Novelty holds a strong place in James's heart, so the idea of being able to select different meditations even over the course of the day felt somewhat meaningful. And he would also attend a mindfulness group with other residents at Cooper Reese daily, and he would practice applying mindfulness meditation, breath attention practices in sessions with myself and with his primary therapist. I've referenced a few articles below. The first deals with kind of the effectiveness in improving emotional regulation, and is actually dealing specifically with self-guided online tools. So that felt pertinent to the Insight Timer app. And the second one, showed, improvement in emotional regulation and distress through a grieving process with the use of mindfulness meditation. And that felt pertinent to James's case, in that a lot of his suicidal ideation and intrusive thoughts and depression seem to revolve around a concept that we call ambiguous loss, and it's almost like he's bereaved, and that he's grieving. He's in the process of grieving the life that he thinks he should have had or wishes he should have. I'm sorry. I apologize for that second link. It does work if you cut and paste it to the search bar. So looking at the data from the 7 weeks that we monitored James's patience level, it's really clear that there was not much of a relationship between the intervention or the intervention plus the tracking of the intervention with any shift or trend in toward deterioration or improvement in patients. You can see that there's a very cyclical nature in the data path, and that was certainly evident in working with James, seeing that he would latch on to the idea that things were improving, and almost the idea of improvement would kind of snowball into improved scores and better functioning in the community and in other relationships for a period of time, and then at the slightest sight of some sign that things were going to get worse, things sure enough would get worse. So again, nothing in the data to indicate that the intervention had any effect on the dependent variable of James's patience level. And oddly enough, I think James did react well to the intervention. I think what was interesting in looking at all this information on the tail end, was that James's scores matched up really well with collateral information that we were getting from the family, from his parents, to whom James was reporting almost verbatim what his psychological experience was like. Meanwhile, the clinical team was seeing more improvement than James or his family were in his ability to tolerate distress without making impulsive, impatient decisions. But as I said, he reacted well to the intervention, but not as we intended, or as James intended to respond to the intervention, or certainly as we measured it. From the measurement, it appears the intervention had absolutely no effect. The evaluation could have been improved by asking a relevant other to record their own perception of James's experience, and for a relevant other, I would have selected maybe a non-clinical staff in the treatment community, like a tech, rather than a member of the clinical team. Again, like with James's parents, he was reporting his own perception of his psychological experience to most members of the clinical team. I also think the use of a standardized scale might have given a little bit more meaning. A standardized scale like the PHQ-9 or Beck's Depression Inventory, I'm not sure, but may have been able to give a clearer perspective on any benefit that James did gain from the intervention, which the measurement that we used certainly did not capture. A shift in our conceptualization of his case, I think, was toward a need for improved emotional intelligence and interpersonal effectiveness. And so maybe thinking that a DBT-based intervention, or an intervention specifically targeting his OCD and decreasing his obsessive thinking, may have been preferable in retrospect. And here are my references to the articles that I mentioned. Thank you.